organizing committee for giving me the opportunity to be standing in front of you guys today. I'm going to be talking, so my talk is half an hour, right, in total. So it's probably, I'm going to be giving the presentation first, and then we're going to be going through a short but interesting case at the end. So this is my disclosure. I'd like to start always my talks with related to aortic valve with this slide. It's amazing that how science have came since Leonardo da Vinci have described the aortic valve in the early days of the Renaissance. So the development of aortic valve prostheses have come along miles and miles since that time. We're talking about valve-in-valve, or TAVI in SAVR. So before we dig into that talk, let's talk about structural valve degeneration. This topic is a hot topic nowadays, and there has been a lot of criticism that have been raised recently, criticizing the surgical literature for the definition of structural valve degeneration. The early published data for surgical valve or surgical bioprosthesis that proved the efficacy and the long-term outcome of surgical prosthesis were depending usually on whether the patient received a redo surgery for the aortic valve or not, and hence the 15 years or the 12 or 15 years of long-term result of the aortic prosthesis came along. And this has been criticized so many times in the literature. Now, what is structural valve degeneration? It's actually, by definition, it's an acquired intrinsic biological abnormality of the leaflet itself or the stent that's holding the valve. It can be calcification, tearing of the leaflet, or retraction of the leaflet. And in this picture, you can see many examples of these. So it is not valve thrombosis, it's not patient prosthesis mismatch, and it's not, or mechanical thrombosis. You can see here that the definition of structural valve degeneration has been all over the place. From this paper here, the definition, there's 20 definition of structural valve dysfunction or degeneration in more than 20 published data or published articles. Danny DeVere and his group of the valve-in-valve registry have suggested this new definition or new staging, let's say, of structural valve dysfunction that I think personally it's going to help us to unify the term and hence speaking the same language. It will help us in pushing this science even forward, and it will help us in unifying at least the published results. So he's suggesting that little pointer here. So he's suggesting, I don't have a pointer. So he's suggesting that we stage it. So it's like mild, moderate, and severe. So stage 0, 1, 2, and 3. And stage 3 is being the severe form of structural valve dysfunction, either regurgitation or stenosis. And he also suggested that based on these stages, we can plan our clinical intervention. So let's talk now about valve-in-valve. So I'm going to take you through the story of valve-in-valve, hopefully shortly. We'll start by this recent meta-analysis that has been published only last year of valve-in-valve. There has been no randomized trial published up to date up to my knowledge, comparing valve-in-valve to redo aortic valve surgery. But this meta-analysis is probably the best published data that we have. They have reviewed more than, they have included 6 prospective articles comparing aortic valve, redo aortic valve surgery comparing to valve-in-valve TAVI. And their initial result, as you can see here, that their procedural mortality is probably equal. The only difference is that patient who had redo surgical aortic valve replacement had more conduction abnormality compared to valve-in-valve. And this is by the nature of the protecting the conduction system by the failed surgical prosthesis. While the valve-in-valve procedure have more vascular complication and more paravalvular leak. How do we do it? So as it has been alluded earlier today, in the mitral talks, we all depend on the true internal diameter of the prosthesis. As you know, there is many prostheses available to us in the surgical world, and every prosthesis is different and designed differently. So we depend on the true internal diameter to decide the size about the transcatheter valve. Now, all are familiar now with the Vinny Papat app. He started with the aortic app and then developed the mitral app for the valve-in-valve, which make our life easy. It's very interesting app. But what you may not or may know is that his app is the idea of the app came from his teenager daughter. So she's the one who suggested to him the idea of this app, and then he came along and produced it to us. There's also other company that did the benchmark mark for valve-in-valve, and this is one example of the stented prosthesis suggested sizing. Now, what are the problem or the inherited problem with valve-in-valve procedure? Coronary obstruction and patient prosthesis mismatch. Initially, in the initial experience with valve-in-valve, the coronary obstruction rate were higher compared to TAVI in native aortic stenosis. It was around 3 to 4%, and this is from the VIVID registry. But with experience and with technical improvement and with improvement in the surgery and the design of the transcatheter valve, the coronary obstruction now is almost comparable to TAVI and native valve. So it's around 1% now. However, it's still a fatal complication, and there is many steps that we should take to mitigate it. This is again from the VIVID registry, a work from Danny DeVere and his group. When he studied the coronary obstruction, you can see here that the implantation position, not only the coronary height or the sinus size play a role in coronary obstruction, but the position of the valve itself and the effacement of the sinuses plays a major role. You can see here the factor that that will affect or increase the risk of having coronary obstruction. There is anatomical factor. This is exactly the same like native aortic stenosis, but also there is a bioprosthetic valve factor. So supraannular position of the valve. Most of the surgical valve are supraannular positions. The high leaflet profile, the internal stent frame. So mitral flow was known to be was notorious in their work and the registry for having the highest rate of coronary obstruction. It's because that the leaflet of the mitral flow is mounted outside the stent, so it's closer to the coronary, and it's usually implanted in a very small root. So patient will have, by nature, will have higher risk of coronary obstruction. So what is the science telling us now? So how do we mitigate coronary obstruction? There has been many techniques to decrease the risk of coronary obstruction, choosing a smaller transcatheter heart valve or implanting lower to decrease the risk of coronary obstruction, or stenting, or having stenting in the left main or coronary artery to decrease the foreseen coronary obstruction. But this is one of the latest technique that has been introduced to our field, which is called basilica. It's bioprosthetic aortic scallop intentional laceration to prevent iatrogenic coronary artery obstruction. And it's basically similar to lampoon technique in the mitral world. It's actually lacerating the leaflet that is supposedly going to be obstructing the coronary ostium. And this is done by electrifying a wire that goes through the the leaflet transcatheterally. And you can see here, there's two examples. On the right-hand side, you can see the leaflet after it has been lacerated. So this basilica technique has been introduced initially in the surgical prosthesis, but nowadays it's being done for also native aortic stenosis, whereas there is a risk of coronary obstruction. So we'll talk about the next problem, which is patient prosthesis mismatch. As we all know, when first TAVR was introduced from Partner 1 and the core valve pivotal trial, transcatheter heart valve were notorious for having the best hemodynamic or better hemodynamics compared to surgical aortic valve, and this is by the nature of their design. However, in valve registry, it has been shown that patient who has aortic stenosis as the primary mode of failure, or patient who has smaller prosthesis, or patient who has higher gradient after completion of the transcatheter valve-in-valve procedure have higher mortality. So if you have, at the end of the procedure, if you have high gradient after you implanted your valve, you did treat the aortic stenosis, but you probably still have to do something else. This has been, again, confirmed. This is from Partner 2. Johnny Webb and his colleague have shown that patient who has higher gradient have higher mortality after valve-in-valve. There has been no statistically significant, but there is trend toward higher mortality in patient with smaller size prosthesis. I don't know if you can see this, but it's 21. So patient with 21 or 19 millimeter of surgical prosthesis will have higher mortality. So what did we do about that? Again, another crazy idea. It's valve fracturing, okay? And it's basically implanting the valve-in-valve and then fracturing the stent. You see the first two picture on the left, the valve is implanted, and then using a true balloon to fracture the stent of the surgical prosthesis to give 1 or 2 millimeter space for the transcatheter heart valve to have better hemodynamics. The bench work has been done by a group from, I think, St. Luke. St. Luke. They have tested most of the surgical prostheses, came up with the balloon needed to fracture those valves, and what are the pressure required, because you don't want to go crazy and then you have rupture of the annulus. There has been some valves that are not amenable for fracture, so they came up with another thing, valve remodeling. So here we have in this schedule, in this table here, valve that can be fractured and valve that cannot be fractured but can be remodeled. So it will still give you the extra 1 or 2 millimeter to decrease the gradient. And then there are valves that cannot be either remodeled or fractured. So this is being now done. There is no comparison or long-term effect or long-term outcome of these techniques, but it's being done, and the safety at least has been proven. What is the technology giving us in the future? This is the new design of the surgical valve. A new design from this is the new Magna valve, this is the new generation of Carpentier-Edward or Magna, with two major technical improvements. First, you can see in the lower corner, in the lower right corner, the size of the valve is there. So if you miss or you don't know what size the valve, by just looking on fluoroscopy, you'll be able to pick up what size valve is this. Second is that what they call is V-fit technology. The stent actually is expandable, so we don't need to fracture the valve anymore. The stent can be expanded to give us the extra 1 or 2 millimeter again for the to be able to accommodate the transcatheter heart valve. This is just a video of the app. but you're all familiar with it right now. So I'm gonna now skip and go starting presenting the case. So this is a native aortic stenosis, a 65-year-old lady with a significant history of severe COPD. She's a long-term smoker. She's also known for hypertension and hypothyroidism. She presented with multiple admission for heart failure. Her COPD has not been changed over the last couple of years. She doesn't use home CO2. Any surgeon in the podium, in the audience? Dr. Marwan? What's your opinion about COPD and operating on patients with severe COPD? So the STS for this patient was 2.4. However, the chances of this patient require long-term ventilation and an inability to wean her off the vent was very high after conventional surgery. So a heart team discussion was done for this patient and we elected to do TAVI on her. She does have a bicuspid aortic valve. This is her one of the echo slices that she had. So aortic valve area was 0.38, mean gradient was 55. She has moderate AI. EF was reasonable, 45%, and she has bicuspid aortic valve. This is an image of her coronary. She had normal coronary with no significant obstruction. This is her CT scan. So annular perimeter of 81.4, and the sinuses are generous. She has significant calcification of the aortic valve, as with the bicuspid patient usually. Dr. Faisal, I want to ask you how do you size for bicuspid valve usually? What about commissure to commissure distance? And okay, so this is what we did here. We also depends on the perimeter of the annulus or the annular dimensions. This patient also, because she was a small lady, her femoral artery was around 4 millimeter or 4.1 millimeter. So our alternative access in the center was direct or transcarotid. So this is an image of her left carotid artery. It was the minimum diameter was around 6.7 millimeter. So she was scheduled for transcarotid TAVI. The first thing we start, as we usually do with bicuspid valve, is pre-dilation. Do you pre-dilate all your patients? So here we did pre-dilation for the valve, as you can see on the right-hand side. However, even with pre-dilation, this is the shape of this. So we're using Evolut R, so self-expandable valve. So you can see here from two different projection of the fluoroscopy image. On the left-hand side, the valve is really compressed. On the right-hand side, the valve looks supraannular, but the diameter looks okay. So it can be sometimes deceiving, right? So this is another point for intraprocedural echo. So this is what the valve looked like on echo. You can see that it's really compressed. and we call it pancake sign. So we proceed ahead and deploy the valve and choose to post-dilate at the end. Because this is a transcarotid approach, this was done in the early experience of the case was done in the early experience of transcarotid approach, and we tried to minimize all the interventions. So we actually, when we do transcarotid, we try to minimize pre or post dilation. However, this patient was unfortunate. So we had to pre-dilate, then again post-dilate. But then at the end, I think we had good results. This is what the valve, at the end, the valve looked like after post-dilation with minimal leak. Thank you so much.